platelet shape change, granular release, and aggregation. And the types of receptors for adhesion and aggregation are different. GPI for adhesion, GP2B3A for aggregation, and some diseases, von Willebrand disease, Bernard-Soulier syndrome, and Lanzmann thrombasthenia. And secondary hemostasis it means the role of coagulation factors. So in primary hemostasis, we don't have coagulation factors here. Just there is the role of platelets and collagen with von Willebrand factor. But in secondary hemostasis, coagulation factors are activated. The first one is tissue factor. That this tissue factor is produced by subendothelial smooth muscle cells and fibroblasts. This tissue factor is a glycoprotein that starts activating other coagulation factors. So this is the coagulation cascade in secondary hemostasis. Tissue factor is activated in vivo, means in body. It's different with in laboratory. In laboratory, we have extrinsic and extrinsic pathways for hemostasis, for coagulation cascade. But in vivo, tissue factor is produced, it activates factor 7, and then they continue with activation of factor 10, and then prothrombin changes to thrombin, and then thrombin activates fibrinogen, makes fibrin, and there is polymerization of fibrin. So here, tissue factor is produced, 2-phospholipid complex expression, which is the flipping of phosphatidylserine to the surface of platelets, making a negative charge on the surface of platelets. Then the coagulation cascade continues with activation of some factors ending in activation of thrombin. Then activation of fibrin and its polymerization. This fibrin makes a meshwork for the platelets and make the hemostatic plug harder. So this is secondary hemostasis. That is the participation of coagulation factors and making fibrin a meshwork for having a harder plug. And at last, some red blood cells and neutrophils, white blood cells are also trapped in this growing hemostatic plug. But together with these thrombotic molecules, endothelium, a healthy endothelial cell, releases some factors, some molecules for lysis of this fibrin. Because this blood clot is not supposed to be present forever. It should be disappear. It should become smaller and dissolve. So some factors such as tissue plasminogen activator is released by endothelial cells that causes fibrinolysis, or thrombomodulin. Thrombomodulin is a molecule that can prevent some coagulation factors. So endothelial cells, by releasing these molecules, can control the hemostatic plug to dissolve it. So platelets, that their role is for platelet adhesion, then platelet aggregation, then the coagulation cascade, that in laboratory it's intrinsic and extrinsic pathways, and in vivo it is activated, as I told you, by tissue factor and activation of other factors ending in fibrin clot formation. Thrombin that is the duty of that has the duty for activation of fibrin has other duties or other actions as well. So fibrin, okay. Thrombin activates fibrin, also causes platelet aggregation. This thrombin, the platelets make thromboxane A2. Thrombin can activate monocytes, neutrophils, and lymphocytes. But this part, thrombin can activate endothelial cells to produce some molecules that prevent this hemostatic clot formation. So thrombin itself has both thrombogenic effects and thrombolytic effects. Thrombin, by activation of endothelial cells, make them release some molecules that they have fibrinolytic and anticoagulant effects. Tissue plasminogen activator, prostaglandin A2, and nitric oxide. This is a free radical which is also a vasodilator. So, a healthy endothelial cell is important to control the hemostatic clot. It produces some molecules that can inhibit coagulation factors. This is an endothelial cell. This is thrombin. This is thrombin that changes fibrinogen to fibrin. Endothelial cell, by having this thrombomodulin molecule, can bind thrombin and inactivate it. And also endothelial cell has a receptor for this protein C. There are two proteins, protein C and protein S, that they can inactivate coagulation factors 5 and 8. So there are some molecules that inactivate coagulation factors, including protein C and S. And endothelial cell can activate protein C. So by having thrombomodulin molecule and also a receptor for protein C, they can activate protein C, which has the ability to inactivate factors 8 and 5. This A after the name of factors means activated. And also endothelial cell has a molecule called heparin-like molecule that this molecule also inactivates thrombin. And by this inactivation, this heparin-like molecule can inactivate thrombin and also factors 9 and 10. So you see, endothelial cells have some molecules that they can inhibit thrombin and some coagulation factors. So this should be present in order to control that thrombin formation. Hemorrhagic disorders. So what causes bleeding? If we have problem in our platelets, including number or function, or we have problems in coagulation factors, or in vessel walls, there will be a risk of hemorrhagic disorder. So, hemorrhagic disorders are divided into defects of primary hemostasis and defects of secondary hemostasis, and generalized defects that they involve small vessels. So defects of primary hemostasis means whatever we have in primary hemostasis, including platelets and von Willebrand factor, but not coagulation factors. As you remember this picture, in primary hemostasis, we have platelets, collagen, and the von Willebrand factor for binding of platelets to collagen. So some of the bleeding disorders are due to defects in primary hemostasis. So it includes problems with platelets and this von Willebrand factor. So von Willebrand disease and dysfunction of platelets or low number of platelets can cause bleeding disorder. But what are the defects in secondary hemostasis? It's clear that problems with coagulation factors, deficiency, for example, of factor VIII, because secondary hemostasis is the coagulation cascade. So, for example, factor VIII deficiency can cause hemophilia A. So defects in secondary hemostasis are defects in coagulation factors. But the clinical picture is different when a patient has defect in primary hemostasis and then has defect in problem in coagulation factors. So a patient with von Willebrand disease or when has low platelet number, which is called thrombocytopenia, or dysfunction of platelets such as Bernard-Soulier, Glanzmann, typically the patient has very tiny hemorrhages on the skin, which are called petechia. Petechia, small 1 to 2 millimeter hemorrhages, as in this picture, this one. This is a segment of intestine, colon. This is the mucosa, but you see very, very tiny hemorrhages diffusely present on the mucosa. This is due to thrombocytopenia, low number of platelets in this patient. So defect in primary hemostasis causes tiny hemorrhages on the skin or in the mucosal coverings. This is called petechia. But if these are larger than 3 millimeters, they are called purpura. So petechia purpura, 1 to 2 millimeter is petechia, and more than 3 millimeter is called purpura. But in a patient that has coagulation factor deficiency such as hemophilia, the type of bleeding the type of bleeding in secondary hemostasis defect is different. The type of bleeding is bleeding in cavities, in joint spaces, for example. A patient with hemophilia, when has trauma to his knee, will have hemarthrosis. So the type of bleeding in secondary hemostasis defects is different with primary. It means that when a patient has coagulation factor deficiency, for example, factor VIII, which causes hemophilia A is due to factor VIII deficiency, and hemophilia B is due to factor IX deficiency. In these patients, the clinical picture is the same. So these patients have hemarthrosis, for example, hemarthrosis, bleeding into joints. So the joint cavity, this knee joint becomes very big. So, but this is for secondary hemostasis defect, but for primary, the patient has petechia and purpura, small hemorrhages on skin or mucosa. So in spaces there will be hemorrhage. Or in cerebral tissue, bleeding in cerebral tissue, this picture is brain tissue and this hemorrhagic tissue. But this has been caused due to an accident. This is a tear and hemorrhage into tissue. So type of bleeding and the clinical picture is different in primary and secondary hemostasis. And if there is rapid loss of blood, more than 20% of blood volume, the patient will have a shock called hypovolemic shock or hemorrhagic shock. So this percentage, remember this percentage, that if there is rapid loss of more than 20% of blood volume, it can cause hemorrhagic or hypovolemic shock. That we will explain types of shock in the shock at the end of this chapter. After bleeding, the bleeding disorders will be explained in more detail in the chapter of hematology, red blood cell disorders and bleeding and clotting disorders. But here our more emphasis is on thrombosis. Thrombosis means clotting, formation of a blood, something like blood clot composed of platelets, red blood cells and fibrin, which obstructs vessels, including veins and arteries. So thrombosis is due to problem in endothelial cells or hypercoagulability state or abnormal blood flow. These three are called Virchow triad. So it's like a triangle that they have a role in thrombosis. So thrombosis which makes masses composed of platelet, fibrin, and red blood cells in veins and arteries, can be due to endothelial cell injury, or abnormal blood flow, or hypercoagulability state, which may be both acquired or inherited. So these three things, three factors, can cause thrombosis, and this is called Virchow triad. Three factors. Endothelial cell injury, as I told you, endothelial cells at healthy state have antithrombotic effect. Antithrombotic effect by those molecules, thrombomodulin, heparin-like molecule, protein C receptor, by tissue.
Yasmin'e çevir. Kuşaklı yansıttık, organikte pek çoğunluğuyla.
Liren zamar pedçildi.
Ha, artık o restoranım է հիմա ոնց ասեմ կհասկանաք, որ ձեր դասացուցակի մեջ փոփոխություն ա, չէ՞։ Դուք արդեն էլ դոկտոր բանի մոտ չեք գնում։ Վերջացրել եք դոկտոր Սուրեն Պերճի, հա, դոկտոր Ֆինիշա։ Հիմա դասացուցակը փոխվելու է։ Ոնց ասեն, դասացակը մի հատ ասեմ,
Your program
դասացակը
is changing. Միայն այսօր է փոխվել։
Չէ, արդեն ապրիլ-մայիսի համար ուրիշ դասացուցակ է լինելու իրանց։
In April and May you will have another schedule.
It is material and
Materiology եք սկսել, բայց materiology Monday չի կարող անել։ Անելու է Tuesday-նա, վտորնիկը, երեքշաբթի ու հինգշաբթի։
Tuesday and Thursday. Okay.
Monday դուք ունենաք, ինչ ունեք, therapeutic stomatology, physiology, go home։ Հա, հետո երեքշաբթի օրը Tuesday ինչ ունեք։
Physiology, միադը physiology,
Հա, physiology-ից հետո materiology, երկու հատ materiology, հա։ Հետո մեկ էլ հինգշաբթի առավոտը, հինգշաբթի ինչ օր է։ Thursday առավոտը դուք դաշ չունեք, չէ։ Այդ հինգշաբթի առավոտը դինելու է materiology։
Thursday morning you have what materiology?
Ինձ հինգշաբթի չունեք, գալիս եք 11 o'clock։ Հիմա գալիս եք առաջի դասը materiology, որը երկուշաբթի չեք անելու։
Tuesday in 9:30 we start class. We have class.
Երկուշաբթի շուտ եք գնում, հա, physiology-ից հետո գնում եք տուն, բայց հինգշաբթի առավոտվանից գալիս եք materiology։
On Monday you will go earlier, but on Thursday instead you will have class.
Երկուշաբթի ժամը քանից պետք է գան։
Չէ, երկուշաբթի 9:30-ից 12-ը դաս ունեք դուք։ Երկուշաբթի առավոտը ունեք stomatology, հետո physiology ու գնում եք տուն։ Եվա, եթե բաց չլինի, կա ասեմ։
Ուրեմն ես երկու մեկ։
Դու շամոպյան շամը ես ասում։ Կանա թե շամոպյան շամը։
شباب يا جماعة ولا فيديو يكون معنا شباب.
So these three endothelial cells, as I said, normally they, by having these types of molecules, tissue plasminogen activator, and by having nitric oxide free radical, prostaglandin I2, they are antithrombotic. But when there is endothelial injury, as due to hypercholesterolemia, so due to hypercholesterolemia, for example, endothelial cell is injured, or any inflammation, and these antithrombotic molecules are not released by an injured, which is called also activated endothelial cell. So when we use the word activated for endothelial cell, we mean that it is injured, and then it can cause thrombosis or abnormal blood flow. Normally, the type of normal blood flow is called laminar. In vessels, blood flows more centrally. This is called laminar blood flow. So the cells, different types of cells, lymphocytes, red blood cells, platelets, they don't have much contact with the endothelial cells. So normal blood flow is laminar. But this laminar flow can change to stasis. Stasis means decreasing the blood flow, and also turbulent blood flow. So two types of abnormal blood flow are stasis, which means that the blood flow stops at some areas or it's very slow, and turbulent blood flow, which means that the blood flow is stronger than normal and it's near the cells. In turbulent blood flow, it's not centrally, but the blood flow is near the vessel wall, so it makes the cells have more contact with the endothelial cells, including the platelets, which increases the risk of binding of these platelets to the vessel wall. So abnormal blood flow is also important and can cause thrombosis. In hypercoagulability state, there are some genetic causes of increasing the activity of some factors such as factor V. And this type of mutated factor V is called factor V Leiden. Leiden is a city in Netherlands, Holland. And it has been discovered first in this city that the mutated factor V gene can be thrombotic. Or another gene is prothrombin gene. When mutated, can be thrombogenic. Or there is an amino acid called cysteine, which is homocysteine, which is developed by methionine. Methionine is an amino acid that can be changed to homocysteine. High level of homocysteine is something like high level of cholesterol. So it is a bad sign. Hyperhomocysteinemia, which can be due to gene mutations, is something like increased bad cholesterol, which is LDL. So homocysteine level in serum is measured, and its high level is a bad sign as a sign of thrombosis. So these can be seen as inherited causes. Some acquired causes of hypercoagulability state is such, an example is cancer. In some cancers, coagulation factors are produced that increase the thrombosis probability, or some cancers produce mucin, and this mucin is thrombogenic. So all these three factors can cause thrombosis, which is the Virchow triad. So endothelial injury is important because it can be thrombogenic, and when there is endothelial injury, there is the risk of atherosclerosis formation, where cholesterol is one of the most important parts that make atherosclerotic plaque. So instead of having anticoagulant effects, an injured endothelial cell has procoagulant effects. Thrombomodulin is decreased, and instead of having fibrinolytic effects, it will have antifibrinolytic effects. So an activated or injured endothelial cell is thrombogenic. And alterations in normal blood flow that I explained, laminar to stasis or turbulence. And pay attention that the stasis is the common cause of thrombosis in veins, but turbulence is the common cause of thrombosis in heart and arteries. So stasis in veins, turbulence in arteries and heart. But aneurysms that I explained today is dilation of vessels. In aneurysms, there is a stasis, slow blood flow. So aneurysm, if it is seen in aortic aorta, especially in abdominal aorta, it's artery, but since it is an aneurysm and a dilated area, the cause of aneurysm here is stasis, not turbulence. Hypercoagulability, I explained some And this factor V mutation, which is called Leiden mutation, is the most common cause of heritable hypercoagulability state. Another syndromes that cause acquired type of hypercoagulability state are called heparin-induced thrombocytopenia. Some antibodies here are produced that cause thrombogenic effects, and also antiphospholipid antibody syndrome. I don't explain this, just know that these two also can cause hypercoagulability states by producing new antibodies. The shape of the gross picture of thrombosis is important. Thrombosis in heart is called mural thrombi, and also in aorta is called mural thrombus. These two are thrombi. One in left ventricle and this one in right ventricle. These are thrombosis. So these thrombosis thrombi has developed in heart, and this has the risk, as I said, of embolization, most commonly to lower extremities. Embolization, these thrombi can separate and start to move, and most commonly travel to lower extremities. And this is the picture of thrombosis. You see dark and lighter areas. In darker areas we have more red blood cell, in lighter areas more platelet and fibrin. And this is called laminations, or some different layers with different colors. These lines are called lines of Zahn. Lines of Zahn. In German, Zahn means tooth. Dandon. Tooth. Do you say also dandon?
Dan.
Dan?
Yeah.
Dan. So Zahn is tooth. And mural thrombi, I said, lines of Zahn. And this thrombosis is attached to the vessel wall. But also after death, there are some clots in body called post-mortem clots. So after dying, there are clots called post-mortem clots. But these are different from thrombosis. They are all reddish, covered by some chicken-type fat tissue. There are no darker and lighter areas. This is important in diagnosing if this thrombosis has been present before death, or it is due to post-mortem clot. So it may be important in autopsy and forensic medicine. Do you know forensic? Law medicine. پزشکی قانونی. Medical law. Law medicine. Forensic is forensic medicine. And then the forensic pathologist that studies on tissues. So these post-mortem clots are not attached to vessel walls, but thrombosis is attached, and we have different layers. So having different layers shows that this thrombosis has been developed in a flowing blood, not in dead state. And the thrombi that occur on valves are called vegetations. And these vegetations can also embolize. And they can also be infected. The inner layer, inner side of heart is lined by endocardium. And when this is infected, it's called infective endocarditis. So an infected vegetation also can transfer the infective material to distant sites. What is the fate of thrombus? Means what is the end result of thrombus? A thrombus can grow and grow with the accumulation of more platelets and fibrin. It's called propagation. But it can also dislodge and travel in circulation, which is called embolization. And there is also the possibility of dissolution of thrombus as a result of fibrinolysis. So a thrombus can grow and become propagated or do embolization or dissolution. In older thrombi, the inner side of the thrombus can become cellular. These cells are composed of smooth muscle cells, macrophages, fibroblasts, and this is called organization of thrombosis. Sometimes the canal is also developed at the center and is called recanalization. So one of the end results of thrombus is organization and recanalization. What are the clinical features of thrombus? They can cause obstruct arteries or veins or emboli. So clinically, a thrombus can obstruct a vein or artery, so there is a risk of infarction and gangrene. In heart, myocardial infarction, in cerebrum, stroke, in extremities can cause gangrene. So they can cause infarction and gangrene, or if they can emboli. And as you know, from the deep veins of legs, most commonly they go to lungs and cause pulmonary embolism. So we have thrombosis in veins or arteries. Thrombosis in veins is also called phlebothrombosis. So venous thrombosis is also called phlebothrombosis. And also thrombosis can be seen in arteries and heart. In veins, as you know, the most common area is veins of legs, but most commonly it is in superficial veins. So the patient has varicosities and some thrombosis in superficial veins, and this obstruction can cause local problems, not systemic. It can cause varicose ulcers, and so the reaction is local. But the danger is when the thrombus is in deep leg veins. Then when it is in deep leg veins, it has the danger of embolization. The problem is that in almost 50% of cases, these deep venous thrombosis patients are with no symptoms, and they are diagnosed when they have pulmonary embolization. And that's the bad part. These lower extremity deep venous thrombosis are more commonly seen in those who are immobilized, have a prolonged bed rest, or have hypercoagulability problems, such as factor V Leiden, or a cancerous patient, a patient with chronic inflammation. These patients have hypercoagulable states. Also in pregnancy, there is more probability of varicosities and deep leg vein thrombosis, or trauma surgery and burns. Not only they cause a person to have bed rest, but also they increase the hypercoagulable state. In cancerous patients, as I said, there is, for example, mucin production, and this mucin, some cancers such as mucinous adenocarcinoma of stomach, of intestine, they produce a lot of mucin, and this is thrombogenic, procoagulant. Or tumor-associated inflammation and coagulation factors such as tissue factor, which is a glycoprotein, and factor VIII. These are released from tumor cells and increase the risk of thromboembolism. In cancers, thromboembolism in metastasized, in disseminated cancers is also called migratory thrombophlebitis or Trousseau syndrome. So this term is used in cancerous patients that have metastasizing tumors. So this thrombosis can migrate to different areas in body, and in these patients, cancerous patients, thrombosis is called migratory thrombophlebitis or Trousseau syndrome.
Increase the thrombocytes with cancer.
Increase the risk of thrombosis, not thrombocyte, thrombosis. Thrombocyte is platelet. And about arteries and heart, atherosclerosis is the major cause of arterial and cardiac thrombosis. So atherosclerosis, which is hardening of arteries due to accumulation of cholesterol and some cells, inflammatory cells. You want to go there? And you are finishing. We are
5 minutes.
Just some minutes. Atherosclerosis is a major cause of arterial thrombosis. So the risk factor for arterial and cardiac thrombosis is atherosclerosis. And myocardial infarction also can predispose to cardiac thrombi. So some patients with myocardial infarction, then they have developed thrombosis in their heart. So one of the complications of myocardial infarction is cardiac mural thrombi. Embolization is separation of these thrombi. When they move, thrombi are attached to vessels. Thrombus is attached, is bound to vessel wall. It doesn't move. When it starts moving to other areas, it is called embolization. So it has the same structure, but moving. So this is the end of thrombosis, and we explained embolism in the morning. So we have also explained embolism. We also have air embolism, that gas bubbles are formed in circulation. And for example, if deep sea divers, when they want to come to the surface of water very rapidly, then some of these gas molecules, especially nitrogen, that is solved in tissues, when the diver comes to the surface very rapidly, this solved nitrogen comes rapidly into the circulation and causes embolization. This is called air embolism. So these people should do this very slowly in order not to have air embolism. Air embolism is different tissues have different sensitivities to air. Such lung can resist and have more resistance to air, more than, if it is more than 100 milliliter, it's risky for lung. But for brain, for heart, they are less sensitive, so just with a very small volume of air, it can cause air embolism.
And in muscles we have.
Also in muscles, yes, in air embolism, this nitrogen can also cause masses and painful masses in muscle,
And
skeletal
patients
muscle.
will die.
Maybe it can be fatal, yes.
When they cut the muscles, the air goes up.
Yes, that's why it's said that they must do it slowly, that this gas, little by little is excreted.
The cause of this is inflammation of Clostridium?
No, this is air embolism, embolization of air, which is most commonly nitrogen for those divers. Gas bubbles are formed in circulation and they move. I said that embolization can be, embolism can be liquid, mass, or gas. So, but the most common cause of embolism is thrombosis. That's why we use the word thromboembolism. But one of the causes is air. And in these patients, in these people, air, big bubbles of gas circulate in circulation. There is also amniotic fluid embolism that is one of the complications of pregnancy during labor. Amniotic fluid can enter the circulation of mother and can cause embolism in lung. So this is you see these are two arterioles in lung of mother, but inside there are some keratin from the newborn. It has come from amniotic fluid. So inside these arterioles belong to the newborn, belong to the fetus, belong to the amniotic fluid of the newborn, these squamous epithelial cells or keratin, maybe hair, which is called, and also fat. Fat is called lanucle, fat that covers the skin of the newborn. This maybe we see fat, hair, or keratin. This is the sign of amniotic fluid embolism in the lung of mother. So we explained the embolism. We have infarction and shock for next time. We will continue, but the exam will be, we didn't have time to do this infarction. So the exam will be until the end of embolism.
From autophagy.
Inflammation and repair. Not cell injury is not, no.